Somewhere around 50 million Americans over the age of 65 are actively managing their blood pressure right now, taking a pill every morning, watching the salt, checking the reading on that home monitor on the bathroom counter, and the number almost all of them are trying to hit the number they were given in a doctor's office and told to chase, maybe putting a meaningful percentage of them at greater risk than the blood pressure they started with. That is not an opinion. That is what a growing body of cardiovascular research in adults, specifically over 65, has been showing for the better part of a decade. And the reason most seniors have never heard it explained clearly is not because their doctors are careless. It is because a 15-minute appointment was never built to hold a nuanced conversation about a topic this layered. I'm Dr. Ryan. I specialize in cardiovascular health and aging, specifically in how the circulatory system changes after 60 and what that means for how we interpret and manage blood pressure in older adults. In my work with adults over 65, the pattern I keep seeing is this. People who have been faithfully managing their numbers for years, doing everything right by the standard they were given, and still feeling off, tired in a way that sleep does not fix, dizzy when they stand up, foggy in the afternoons, and nobody has connected those symptoms to the medication sitting on their kitchen counter every morning. That is what this video is about. Not scare tactics, not telling you to stop your medication. What it is about is giving you the actual picture, the one the research supports, so that the next conversation you have with your doctor is a real one. Stay with me, because by the end of this, you are going to understand your blood pressure numbers differently than you did when you clicked on this video. And that understanding is going to matter. There is a specific kind of weariness that settles into adults past 65 who have been managing a chronic condition for years. Not dramatic, not the kind that sends you to the emergency room, the kind that just quietly narrows life. The morning walk gets a little shorter. The grandkids' soccer game feels a little more exhausting than it used to. The reading on the bathroom monitor goes up slightly, and there is that familiar pull in the stomach. Am I doing something wrong? Did I eat too much sodium yesterday? Should I call the office? That vigilance is exhausting in its own way. And what makes it worse is the suspicion, quiet, rarely spoken, that maybe the number they told me to hit was never actually right for someone my age. That suspicion deserves a real answer. And the real answer starts with understanding what blood pressure actually measures and why the same number means something fundamentally different in a 45-year-old body versus a 70-year-old one. Your blood pressure reading has two numbers. The top number, systolic, measures the pressure your arteries experience when your heart contracts and pushes blood out. The bottom number, diastolic, measures the pressure between beats when the heart is resting and refilling. For most of the 20th century, clinical medicine focused primarily on the diastolic number, that bottom figure. Textbooks from the 1970s treated an elevated diastolic as the main marker of cardiovascular danger. Then research shifted. By the late 1990s, it was clearly established that in adults over 50, the systolic number, that top figure, was the stronger predictor of cardiovascular events, heart attacks, strokes, heart failure. That shift matters because of what happens to the arteries as the body ages. Young, healthy arteries are elastic. They flex and absorb the force of each heartbeat the way a rubber hose handles water pressure. They expand slightly with each pulse and smooth the flow. As the decades pass, those arterial walls gradually stiffen. The elastin fibers that give them flexibility break down. Calcium deposits accumulate. The vessel walls become less like flexible tubing and more like rigid pipe. What that stiffness does to the systolic number is direct and significant. When the heart contracts against stiff arteries, the pressure spike is higher and sharper because there is no elastic give to absorb it. So the systolic number climbs. Meanwhile, the diastolic number, the between beats pressure, may stay normal or even drift lower because stiff arteries also lose some of their ability to maintain pressure during that resting phase. The result is a pattern called isolated systolic hypertension, top number elevated, bottom number normal or low. And this pattern is not rare in older adults. It is the dominant form of hypertension in people over 65. It is also critically a physiologically different animal from the kind of hypertension seen in younger adults. Treating it as if it were the same thing with the same targets, the same aggressiveness, is where the problems begin. In 2015, a landmark federally funded study called the SPRINT trial published results that shook the cardiology world. The study enrolled over 9,300 adults at elevated cardiovascular risk and divided them into two groups. One group was managed to a standard systolic target below 140. The other group was pushed to an intensive target below 120. The question was simple. Does getting that number lower faster produce better outcomes? The headline answer appeared to be yes. The intensive treatment group had significantly fewer major cardiovascular events, fewer heart attacks, less heart failure. The results were compelling enough that the trial was stopped ahead of schedule. And within a year, major cardiology organizations updated their guidelines, pushing the recommended blood pressure target for most adults to below 130/80. That is the guideline driving an enormous number of prescriptions today. Here is what the headline left out. And this is the part of the SPRINT data that received a fraction of the coverage the main result did. The intensive treatment group, the one pushed below 120, also had significantly higher rates of serious adverse events. Acute kidney injury was roughly 50% more common in that group. Dangerous drops in blood sodium and potassium were elevated. Falls requiring medical attention were more frequent. Sudden loss of consciousness, Singapore, occurred more often. And when researchers looked specifically at the older, more physically vulnerable participants in the study, the balance between cardiovascular benefit and serious harm looked markedly less favorable than it did in the younger, healthier subgroups. The researchers themselves noted this. Subsequent analyses noted this. Geriatric medicine specialists have been noting this for years. The SPRINT results, they argued, should not be applied uniformly across all adults and should be interpreted with particular caution in older patients where the trade-off calculation is fundamentally different. That nuance never made it into most clinical conversations. What made it in was the number get below 130. And millions of seniors have been living inside that target ever since. Many of them experiencing exactly the side effects the data predicted without anyone connecting the dots. I want to tell you about a patient I'll call Harold. Harold was 74, a retired electrician from Columbus, Ohio. He had been managing his blood pressure for about 6 years, well-controlled, stable, no major issues. When the guidelines shifted, his primary care physician adjusted his medication to push his systolic below 130 per the new recommendations. Harold was a compliant patient. He took everything as directed. Over the following 3 months, Harold's wife noticed he was moving more slowly in the mornings. He mentioned a couple of times that he felt unsteady getting up from his recliner. He chalked it up to age. She chalked it up to age. His doctor at a routine follow-up saw a systolic of 124 and told Harold his pressure looked great. 6 weeks after that appointment, Harold caught his foot on the edge of the garage step, went down hard, and fractured his wrist. When I reviewed his readings and did a standing blood pressure test in my office, measuring his pressure seated, then again within 2 minutes of standing, his systolic dropped 28 points and his diastolic dropped 18 points the moment he stood up. Sitting in a chair, his pressure looked controlled. The moment gravity made a demand on his circulation, his body could not compensate fast enough. When I adjusted his medication to allow a resting systolic closer to 138, the morning unsteadiness resolved within 2 weeks. Harold's exact words when he came back in were, "I didn't realize how much I'd been white-knuckling every time I got out of a chair. I thought that was just what getting older felt like." It was not age. It was a medication target that had never been calibrated for his specific physiology. What Harold experienced has a clinical name, orthostatic hypotension, and it is one of the most under-recognized and under-discussed blood pressure dangers in older adults. Orthostatic hypotension means a significant drop in blood pressure that occurs when a person moves from sitting or lying down to standing. Clinically, it is defined as a drop of at least 20 points in systolic pressure or 10 points in diastolic within 3 minutes of standing. In younger adults, the body's barrel reflex, the automatic system that detects and corrects pressure changes, responds quickly enough that this drop barely registers. A brief head rush gone in a second. In adults over 65, that barrow reflex response slows. Blood vessels are less responsive. The autonomic nervous system, which coordinates the rapid compensatory tightening of vessels when you stand, operates with less precision, and blood pressure medications that lower resting pressure make every one of those mechanisms work harder to compensate, meaning the drop when standing becomes larger and more sustained. The consequences are not abstract. Hip fractures in adults over 70 carry a 1-year mortality rate approaching 30%. A medication-induced fall is not a minor side effect buried in fine print. For a 71-year-old who lives alone, a fall in the bathroom at 6 o'clock in the morning can be the beginning of a cascade that ends independent living. Yet the standard blood pressure measurement taken at a clinical appointment, the reading your doctor uses to evaluate your control, is taken seated after 5 minutes of rest in a climate-controlled room. It captures one slice of your pressure profile. It tells you almost nothing about what your circulation does the moment you stand up and walk to the kitchen. Now I want to explain something called the J curve, because this concept is at the heart of why the question of how low is too low is not a fringe concern. It is a documented cardiovascular risk. When researchers map blood pressure against cardiovascular outcomes across large populations, they expect to see a straight line. The higher the pressure, the worse the outcome. And they do see that across the upper range. But what the data also consistently shows, particularly in older adults, is that as blood pressure is pushed below a certain threshold, risk does not keep falling. It begins to rise again. The graph looks like the letter J, risk climbing at the high end, dropping through the middle range, and then quietly rising again at the low end. The most clinically significant expression of the J curve in seniors involves the diastolic number, that bottom figure. Multiple large studies have found that diastolic pressures below approximately 60 to 65 millimeters of mercury are associated with increased risk of cardiovascular events, cognitive decline, and organ damage in older adults. Here is the mechanism, and it matters that you understand it. Between heartbeats, the phase the diastolic number reflects is when the coronary arteries, the vessels that feed blood to the heart muscle itself, do the majority of their filling. The heart, while it is resting and refilling, is also being resupplied with oxygen-rich blood through those coronary vessels. If diastolic pressure drops too low, that resupply is compromised. In an older adult whose coronary arteries already carry some degree of narrowing or calcification, which is the majority of adults over 65, a diastolic of 58 is not just a number on a monitor. It may represent a quiet ongoing oxygen deficit to the heart muscle with every single heartbeat. A major analysis published in the Journal of the American College of Cardiology found a clear J-curve relationship in elderly hypertensive patients with meaningfully elevated cardiovascular risk when diastolic pressure fell below 60. That research exists. It is not obscure. But the clinical conversation about blood pressure targets in older adults remains almost entirely focused on the top number and says very little about how low the bottom number is being pushed in the process. So what is the right target after 65? That is the question this entire video has been building toward, and I want to give you a real answer. The honest answer is that there is no single ideal number for every adult over 65. Anyone who hands you one universal target without knowing your age, your functional status, your kidney function, your fall risk, and your specific medications is giving you a simplified answer to a nuanced question. What the current evidence does support clearly across multiple studies and endorsed by geriatric medicine specialists is this. For adults between 65 and 75 who are in reasonably good functional health without significant frailty, a systolic target in the range of 130 to 140 is generally appropriate. The cardiovascular benefits of tighter control in this group are real as long as the diastolic number is not being pushed below 65 in the process, and as long as orthostatic drops are being monitored. For adults over 75, and particularly for those who are managing multiple conditions, have any degree of frailty, have cognitive concerns, or are at elevated fall risk, a systolic target of 140 to 150 is increasingly supported by the geriatric medicine literature as the appropriate individualized goal. This is not relaxed medicine. This is precise medicine. The question in this group is not whether lower is better in theory. The question is whether the specific risks of aggressive treatment in this specific patient outweigh the benefits. And for every adult over 65 on blood pressure medication, there is one question that should be part of every medication review that almost never is. What is your diastolic number running? And what happens to your pressure when you stand up? Before your next appointment, here is exactly what I want you to do. Find out what your diastolic pressure has averaged over the past 3 months. If you have a home monitor, pull your logs. If you do not, ask your doctor's office for your recent readings. If that bottom number has been running consistently below 65, that is not something to note quietly. That is something to bring to your doctor explicitly and to ask whether the medication level producing that number is appropriate for your age and risk profile. Get a validated upper arm blood pressure monitor if you do not already have one, not a wrist monitor upper arm. Take readings twice daily for 2 weeks at the same time each morning and evening. Sit quietly for 5 minutes first. Take 2 readings and record the average. That log is more valuable than any single reading taken in a clinical setting. At your next appointment, ask your doctor 2 specific questions. Ask what systolic target is being used for you and why that target was chosen for your specific age and health profile. Then ask whether your medication has ever been evaluated for its effect on your standing blood pressure, not just your seated reading. If you experience any dizziness, unsteadiness, or light-headedness when rising from a chair or bed, report that explicitly at your next visit. Use the phrase orthostatic hypotension. Ask for a standing blood pressure measurement taken sitting, then again within 2 minutes of standing. That one simple test can reveal a medication-driven pressure drop that a standard clinical reading will never catch. And if you are over 75, currently managed to a target below 130 systolic, and experiencing unexplained fatigue, mental fogginess, or more frequent dizziness than a year ago, bring those symptoms directly into the blood pressure conversation. Ask whether the intensity of your current treatment could be a contributing factor. That is a medically legitimate question supported by current research, and you are entitled to a direct answer. If you start applying this, getting the home log, checking the diastolic, asking for the standing test, here is what you might notice within the first week. The act of actually tracking your readings at home rather than relying on one number from a clinical visit gives you a more accurate and less anxiety-producing picture of where your pressure actually lives day to day. Most people find it is more variable than they thought and less uniformly alarming. By 2 weeks. If you bring your log to your doctor and have the conversation about diastolic pressure and orthostatic testing, you will likely be having a more specific and more productive conversation about your management than you have had in years. And if a medication adjustment is warranted and made, the physical changes, less morning grogginess, less unsteadiness on rising, more consistent energy through the afternoon, often become noticeable within 2 to 3 weeks of a well-considered change. There is one person I want you to think about right now, not a friend in general. The specific person in your life, a spouse, a sibling, an adult child managing a parent's care who takes a blood pressure pill every morning, checks a number on a monitor, and has never once been told that the target they were given was built on research that did not specifically study people their age. That person needs this conversation, and you are now the one who can start it. Here's what I want you to do today. Within the next hour, before this information gets buried under everything else, pull out your blood pressure monitor. Take a reading seated. Then stand up, wait 2 minutes, and take a second reading. Write both numbers down. That is it. That is the beginning. Do that every morning for 30 days and bring the log to your next appointment. By the end of 30 days, you will have something almost no senior walks into a doctor's office with the real longitudinal picture of how your blood pressure behaves across positions, across times of day, across what you ate and how you slept. That is the data that turns a 15-minute appointment into an actual conversation about your actual health. I read every comment on this channel. Tell me, drop one of 3 things below. Write my numbers if you want to share what your pressure has been running. Write getting clarity if you are bringing these questions to your next appointment, or write overtreated if something in this video made you wonder whether your current management is affecting how you feel every day. Every one of those comments matters, and I respond to as many as I can. Next week, I am covering something that connects directly to everything we discussed today. The specific kidney markers your doctor should be checking if you are on blood pressure medication, and why most standard lab panels miss the early warning signs entirely. If you are on medication for your pressure, that video could matter more than this one.